the podcast, which is focused on patient safety and quality. I have with me Dr. Narayan Pendse, who's the Vice President, Fortis Healthcare. He's responsible for the medical strategy and operations there. And the conversation with Dr. Narayan Pendse is going to be on the role of clinical governance and clinician involvement in the quality and patient safety in healthcare. Welcome to BW Healthcare World, Dr. Pendse.
Thank you.
Dr. Pendse, can you elaborate on the principles or examples from other countries which have implemented clinical governance? What does clinical governance mean?
Yeah, sure. I guess that's a great question to begin with. So, see, essentially, what clinical governance means is that making sure that there is an accountability on what the quality of care is being delivered, irrespective whether it is in any setting. It may be a primary health center, it may be a tertiary hospital, it may be a corporate hospital, a public hospital. So essentially, what it means is creating more accountability with a larger framework of quality and patient safety. In terms of countries which have instituted clinical governance, well, there are many. And see, this is a journey. So there are different countries, different health systems at different points in time in their, individual journeys. But nevertheless, clinical governance, if one has to give due credit, it started in the United Kingdom, in England. Their public health, service provider, which is NHS, which is one of the largest health systems across the world, is the one which actually started clinical governance, and this was in late 1990s. And it was there when some, incidents related to poor quality of care were highlighted. And they came out of reporting actually, by peers, by doctors themselves who were not very sure about some of the work which was done by their colleagues. And this was with the intent of, improvement of quality. It was not to pin a blame on an individual, but essentially it was UK where clinical governance started. It was in 1997 that they actually set up a national commission for healthcare safety and quality, and a National Institute of Clinical Excellence. UK was where the entire story of clinical governance started. Of course, with in recent times, with more awareness, both in care providers as well as amongst patients themselves, a lot of transparency is now coming up into data sharing, availability of data, and accountability towards the care being provided. Even in Asia, if you take examples of, let's say Singapore, for example, the Ministry of Health has done a lot of work in clinical governance. Australia has done a lot of work in clinical governance. US, etc., through their payer sources, through their accreditation systems and standards, have done a lot of work. India is now starting to look at clinical governance, and I'm sure we'll talk a little bit more about that in today's podcast.
You started talking about India. So, is it feasible to implement clinical governance in the Indian setup of healthcare? What are some of the challenges that you think are there?
Yeah. Uh, so in terms of feasibility, it is definitely feasible, and clinical governance is not something which is the monopoly of a rich or a better healthcare system. It can be done in very meager health settings also. But we need to remember a couple of facts. One is that yes, while private healthcare in India is flourishing since many years, and we are an anomaly in certain sense of the word, that bulk of the patient care delivery, particularly acute care, tertiary care, etc., is provided by private healthcare, unlike most of the other advanced healthcare systems of the world, where it is largely the public health provider who takes care of these. Of course, there are private clinics and hospitals in those countries also, but they are only for the very rich who can afford those kind of insurance premiums, etc. So one is that in India, it's the private sector, unlike many other countries, which is predominating, where the interests are different, because it's a for-profit industry, unlike many of the other research institutes and public settings. The second issue is that we still have quite a bit of shortage in terms of the good or adequacy of the personnel which are required for care delivery, be it the number of doctors per population, ratios, etc., the number of hospital beds, number of acute care beds, etc. So we are still in the expanding phase of healthcare, where we are trying to reach, the optimum numbers. So when you're struggling for numbers or trying to, expand quickly, obviously some of the things take a backseat, which happens naturally. That should not be the case, or that should not be a showstopper for instituting clinical excellence, but it does play a part. So those are some realities which we need to be aware of. However, there are examples, and with the increasing presence and acceptance of, accreditation systems like, let's say, the National Accreditation Board for Hospitals, NABH, is doing a great job since last almost 20 years. We are also looking at, more and more support from the Ministry of Health, and from other, bodies, whether it is advocacy bodies by doctors themselves or by patients. They are now becoming more aware, and all these are good tailwinds for clinical governance in India. And this is probably the best time, with more and more digital data coming in, with the government also launching the Ayushman Bharat digital mission for EMR and EHR, etc. Because, see, fundamentally, any quality initiative depends on the quality of data which is coming in. If you don't have good data, how do you make any decisions based on that? So this is the right time, I suppose, and to build on, the examples that we have in India itself, both in private as well as public sector.
And Dr. Nair, when we look at the governance, anything that has to take off and become part of the system needs a mindset change. And I think clinical governance is something which requires a mindset change. But for acceptance at every level, like you said, it is something which is feasible at every stage or every shape and size of the organization. How can the government ensure clinical governance through regulatory and statutory authorities? Do you think what's the role that they can play?
So, to be honest, regulatory and statutory would play a limited role in, promoting and instituting clinical excellence, largely because, essentially, it is about truthful reporting of what is being done, or what are your outcomes of, care. Let's say, for example, what are the complication rates for any procedure that a hospital or that a surgeon does. And these are sometimes, sensitive areas, and having laws or regulations to, manage these may not be the best strategy. They can supplement, for sure. Let's say, for example, is the doctor who is, conducting that particular procedure, is he qualified and trained to carry out that procedure or not? Now, that is something which is zero tolerance. I mean, that should be, and that's where, legal and regulatory part comes in. But in terms of reporting your own, instances where things could have gone wrong or did go wrong, because ultimately we all learn from our mistakes, and, doctors are no different, medical care is no different. But if we don't talk about our mistakes, or if there is fear of reporting, that, if I report that, there were these instances in my hospital or in my care, or, wherever it might be, then the purpose gets defeated. Because if you don't disclose, if you don't share, then there is really not going to be any quality improvement. So law, many a times, law is something to be feared about, by and large. So that becomes a little counterproductive to instituting clinical governance. But in terms of supplementing, making sure that, the right person is doing the right procedure at the right time in the right manner, definitely that's the bedrock for, anything in patient care delivery.
And Dr. Pense, according to you, how would you rate the involvement of doctors in the quality initiative in our country? I mean, we are a very unique nation when we have a very unique way of, doctors operating. Like you said, they sometimes, when you put a law, it creates a fear, and that's not what we want. But at the same time, we are operating in a country where there has been instances of violence against doctors for negligence.
Yeah. No, that's a very important, point. And I would say that doctors at this point in time play a limited role. Uh, I don't think it's only because of choice or because they are not interested in something like this. Fundamentally, I am a firm believer that all doctors are inherently and acutely aware about their responsibilities towards a patient, about making sure that whatever they do themselves is in the interest of the patient, and also about the quality of the outcomes that they are providing. uh, Sometimes it gets sidetracked or diverted, simply because of the pressure of maybe the pressure of volumes, that if I'm in a public sector big volume hospital, for example, my fundamental duty would be to take care of my patients. I mean, I'd rather focus on getting my patients out, in time, and as per the benefit that I thought I would be able to give them with the procedure or the treatment. So that becomes the primary responsibility, and this unfortunately gets seen as something which is, just something to be kept on the side, and okay, maybe attending a meeting and kind of talking about it. But that's what happens. But having said that, it's not that doctors are not involved, and we have many examples today in the country. Both doctors and nurses, by the way, many a times we forget nurses play a big role in healthcare, even in clinical governance. We are seeing more and more doctors taking up leadership roles in healthcare organizations, which is a very positive sign. And it is doctors and nurses who are driving the accreditation systems. I'm repeating myself, but like JCI, NABH, and other accreditation bodies, they are doing a lot to promote clinical governance. And a lot of doctors are playing an active role, as assessors themselves, going to different hospitals, assessing the systems and learning. An important part of clinical governance is also cross pollinating good ideas and good practices. So that is what happens when doctors themselves get involved. Because see, if a manager or a quality person goes and learns something and tries to tell a surgeon, hey, doc, why don't you try doing this, it doesn't work. But when the surgeons themselves, for example, orthopedic surgeons, general surgeons, when they kind of go and visit different hospitals, or are provided forums where they can discuss these kind of ideas, and these are of greater public good. For example, use of antibiotics. We all know that antibiotic resistance is a big problem which is there. It's a global emergency. But in today's time, doctors are becoming very aware of antibiotic use, which was unlike the case, say, 3 or 4 years ago. So this is happening because people are now talking about it at different forums, and an awareness is being created. So something like that also needs to be done for patient safety, for quality of care, and clinical governance. And one important thing, to on the previous questions that you were asking. Uh, so in many of the advanced healthcare systems, there is something where there is an indemnification in law of something which I am voluntarily reporting from the spirit of quality improvement. Unfortunately, that does not exist in India. So today, I may report something, let's say a near miss or something that went wrong during a procedure, with the interest of learning and sharing with my colleagues. But I would be very hesitant to put it down in a case file or in a paper, because it could be produced in the court of law and it would be held against me or the hospital, or whatever the case might be. So creating those kind of legal and regulatory support frameworks for quality improvement, realizing that mistakes are opportunities for learning, and quality and system improvement is something that we all need to work towards.
And Dr. Pense, what is your take on the level of patient safety measures that are implemented as of now in various private and government setups?
So I think it would be a mixed bag, to be honest, because private healthcare is, for reasons good or bad, they are always under the lens, be it from the patients, be it the communities, be it the government themselves or different agencies, etc. So in terms of basic patient safety measures, I think by and large, and private hospitals are also a spectrum. It's not only the big corporate hospitals, but there are also many small players, nursing homes, standalone clinics, care deliverers, etc. So it's an entire spectrum where we see. But by and large, they do have some accountability towards patient, because when the patient is paying money, they expect a certain service to be provided to them in a certain manner. So they have to take care of basic patient safety measures. Let's say identifying a patient, before any procedure or before drawing blood or before a surgery. Let's say a surgical safety checklist being followed in the operation theater, where there's a certain way in which you do the pre-operative checks to make sure that you are operating on the right patient, the right side of the body, the right limb, etc. So those things are pretty much okay in terms of hospitals which have some sort of governance. And again, accreditation has played a big role in creating this awareness, but many of them may still be lacking in terms of many patient safety measures. Simple example, taking an informed consent from the patient. In many of the hospitals, the consent is seen as a mere formality, but in terms of patient safety, it's a great tool, because that's an opportunity for the patient and doctor to discuss about all aspects of the procedure that is to be carried out. It's not just a mere signature that one does, but it's supposed to explain everything, that what are the risks, benefits, or alternatives to that procedure. What is it that the patient should expect in a short term and a long term basis? But unfortunately, that does not happen. And I believe in government hospitals and public hospitals, it is even worse. Again, not because of design or intent, but I guess it's simply because of the volume of cases that that they handle, that sometimes these things get overlooked.
And Dr. Pense, one thing that comes to my mind is that when you mentioned about private setups, you said that patients have an expectation which the hospital needs to fulfill. So there are a lot of these assumptions patients come with that, I will be taken care of, I'm at the right place, which makes me believe that patients' expectations also have a role to play. And, so when they go to a government hospital, is their expectation low? And that brings me to my next question, that do you think that there are some unique challenges in the implementation of patient safety measures in a government setup?
Well, yes and no, to be honest. And I will be the first to admit that some of the best clinical minds of this country, or maybe even of the world, are found in our government hospitals and in some of our government funded research institutes. And there are quite a few of them. I mean, AIMS is the most cited, but of course there are many more across the length and breadth of this country. And it's because of them that people go, largely they flock to these kind of hospitals. So, in terms of clinical talent, there is no dearth, and patients do go there. I think patients avoid sometimes going to these setups simply because of the volume of patients who are there, and of course the kind of some of the basic requirements which many may have, including, let's say, a clean room to yourself, and in a structured manner, things being done, whether it is simply settling a bill or whether getting something organized for your patient. So it is that running around here and there, which many times the patients are not very comfortable with, and that's the reason they end up in the private sector, where at least these kind of basic amenities are a given, that there would be a nurse or a security or a housekeeping or a junior doctor on the floor and all that. So I think that is the primary factor is not that it's clinical talent which draws, or necessarily patient safety which does. But by default, when you are paying as a consumer, you have a right to ask questions, and that is becoming more important. In fact, the biggest driver today for patient safety is coming from patients, because once the consumer is aware of his or her rights and responsibilities, and also about they get educated themselves about consent practice, like I was talking about. Today's patients who go to any corporate hospital in a metropolis are far more aware. They have read about their procedures, and they do ask the questions to their doctors, and they want them to be documented, the answers, etc. So it's a lot of it is coming from this, and driving the private sector to be on their toes, which stimulus does not happen in most of the public sector hospitals, unfortunately.
Sir, that brings me to a question that when you're looking at a government setup, somebody is paying for it. I mean, it's the general public through their taxes are paying for it, or the government is paying. But does that take away the risk? Just because the patient is not the payer in the direct sense, does that take away the responsibility of the institution or the doctor of being responsible for the clinical governance that they need to provide?
Not at all. Not at all. In fact, in the court of law, and this is there are multiple instances around this. Whether the patient has paid for a service or not, it really doesn't matter, because as a doctor, your duty remains the same. You would apply the same diligence, you would apply the same safety standard, you would apply the same care standard. It's only that the setting may change. The place where I'm carrying out the treatment may be different. It may be more comfortable for me and my patients in say X setting versus in Y setting. But in terms of my accountability, my responsibility, it remains the same. However, we need to remember that not everything that we discuss gets into medical negligence. That's probably the far end of the spectrum. But there are many more things which happen during the course of the patient's admission till discharge, and those are the things where if you are paying for that service, you ask question about everything, or you have a right to ask question, and you are acutely aware of that right. But if you're not doing that, even at an individual level, it kind of dilutes. And then if you have a complaint, it sometimes becomes difficult to find the right person where to go and voice that complaint. But in a private hospital, it's relatively easier to do that, because you have people from patient experience and patient welfare. You have signages which tell you that in case you are not satisfied, call this number or something. And then there is social media. I mean, you don't like something, you can just post something on let's say social media, and because it impacts the brand, obviously people are going to run to make sure that the damage is controlled. It's misused also, but then such are the times that we live in.
And Dr. Pense, we had spoken about the role of doctors in clinical governance. According to you, how far do you think that the clinicians in this country are involved in the quality and patient safety initiatives by the regulatory and statutory authorities?
Yeah, uh, I think the it's quite limited at this point in time. It's limited not because doctors don't want to do it, or that doctors are not aware of it, but it's largely because this is not seen as the primary responsibility. See, this is not something which is taught to us in our medical schools. This is not something which is part of a practical training or internships that we undergo. I'm talking about a structured manner. Of course, if you have the good luck of being tutored by a professor or somebody who has been practicing something like this or is aware of, but those are rather exceptions, than the norm. So the best is, as they say, to catch them young. So if these kind of things, the and things are changing now. The curriculum by the National Medical Commission, which is being drafted, is now incorporating things about patient safety and quality. But it's just a start, and it's going to take a few years for these to bear fruit. But once that happens, that will be for good. In the interim, I think more and more professional societies, like bodies of, let's say, surgeons, orthopedicians, gynecologists, etc., in their conferences, in their CMEs, etc., are now starting to talk about quality of care, voice of customer, patient safety, which is a very healthy sign. Because once you see your colleagues talking and practicing something which you are not doing, that becomes a big motivator for people to start doing that. Many of them do it simply to start talking about it, but that's the first point. More and more people talk, create an awareness within their professional circles, within their clinical fraternity, outside, in their institutions, etc. I think that will encourage more and more people to join the quality bandwagon.
Dr. Pense, I in January went to Middle East and I had the opportunity to meet a lot of doctors. And just few days back, I was in the US and I saw doctors working there. Now, they don't have enough pressure that we see in India. They have a lot of time, which allows them to comfortably, in their time that is available to them, fulfill all the compliance that is required. But in India, if you go to the hospital, the doctor is overworked. He has 50 patients waiting outside to meet him. He's struggling to complete his OPD during the day and take out time to go visit his, IPD patients. Keeping in mind the workload faced by the clinicians, do you think that prevents them to get actively involved in the quality process making? What is your take on this?
So yes and no, to be honest. Yes, it's a deterrent. It's a deterrent, I'm sure, for many people who don't have a choice in this matter, because if you have so many people, registered to see you on a particular day, you need to make sure that you or somebody from the team does that. But then there are many people who don't have that necessity or that obligation to do that. If they want, they can curtail the number of patients that they see or they admit, and they could utilize some of that time, to help institute some of these things, because these things, they play a vital role overall in system improvement, which translates into better quality of care for their own patients also. I'll give you a small example. In today's time, care is multidisciplinary. It's a team of people which works together. Many times there are different clinical specialists. Let's say a surgeon, a diabetologist, a neurologist, a nephrologist have to work together, because the patient has multiple, comorbidities, maybe hypertensive, may have kidney failure or stuff like that. There are nurses, there are dietitians, there are physiotherapists who all work together. Now, if a doctor says that, hey, my job is only to take care of my surgical part and this is, somebody else's, that is one way of doing it. But from a patient centricity, from a patient safety perspective, from overall quality of care and outcome, it doesn't work. So I need to make sure that the entire team is better suited, is better trained, is more optimal and efficient to deliver good quality care to my patient. Now, in order to develop that team, in order to have a protocol or algorithm based working where possible, I myself need to find some time for that. If I say, hey, my job is only to operate and I'm going to operate more and more because that's what fundamentally I'm supposed to do, and I ignore the other part, is that being fair? In the long run, it doesn't help. On the contrary, if my outcomes are poor, because overall the ecosystem I am not contributing to improve, it's going to harm me and my patients more. So it's being myopic, in certain senses. But of course, there are many who do not have a choice. Many colleagues from the government setups, etc., where there are 120 patients which are supposed to be seen in a particular day's time in the OPD. They are hard pressed for time to find to for any other activity, whether it is research, whether it is quality improvement or anything else.
And Dr. Pense, my last question to you before I let you go is, what will be the top three interventions which you think will get the clinicians to get involved in patient safety and quality?
Yeah. I think first and foremost would be to create an awareness around patient safety. And patient safety is just one small phrase, but it encompasses a lot of things. In fact, in medical education, right from Hippocratic Oath times, it is first do no harm, is the tenet. So it stems right from there. So it's not something which is new, but creating an awareness of how to have a good patient safety ecosystem around us is something which is very important. And this is not only the doctor's responsibility, this is everybody's responsibility. It is responsibility of the hospital managers, it is responsibility of the policy planners, it is responsibility of the regulatory and statutory bodies, it is responsibility of the society too, it is responsibility of the, like I said, professional associations, etc. So everybody needs to contribute to this, because this fundamentally will educate and empower all stakeholders in patient safety. So that, I think, would be the first thing. People like you and me, this opportunity for a podcast which is being done on patient safety and clinical governance is a small opportunity to create this kind of awareness. So that is first. Secondly, I think creating forums or institutions where these kind of things can be discussed, because like I said, fundamentally it is about learning from mistakes. If you do not have forums or societies where you can talk about these things, it is not going to lead to improvement. And unlike, let's say, airline industry where everything is monitored and under surveillance, etc., and it gets reported to the DGCA and stuff like that, in medical practice it doesn't happen, and it's not possible to have everything monitored 24/7, 365. It doesn't work like that. So the idea is to create a culture where people are not fearful of reporting or talking about some of the things that they were part of or they witnessed, so that others learn from those, reporting of incidents, as it is called. And because incidents will happen, healthcare is medical care is complex, it has many opportunities where things can go wrong, and they do. So creating these kind of bodies, associations, etc., to help people discuss candidly, to learn from each other, and even at a national level to do that, would be the second thing that I would say is very important. And thirdly, creating a supportive legal and statutory environment. I gave you the example of indemnification, because if people are fearful of even writing down what they should do in many instances, simply because it may be held against them in a court of law at some point in time, is a big deterrent. So some kind of indemnification mechanism needs to be put into place for these. These are the three recommendations that I would make.
Dr. Pense, I think it has been a very meaningful conversation because while it was clinical governance, like you said, pioneered out of UK, but I think it is something that is finding its way in healthcare delivery across the globe, and India is not away from that. And I think the very important point that you brought out in the conversation was that we have to take the fear away from the doctor to be able to report in the spirit of improvement and making healthcare uh, more quality driven and more system oriented. And another thing that caught my attention was the word culture. I think it has to become a culture and part of the mindset of every clinician, every medical practitioner, that it is, while it is not your primary responsibility, it is an integrated part of your responsibility as a quality healthcare uh, delivery person. So I think with that, thank you so much for taking our time to speak with us on this extremely important topic. And I'm glad that Kaho has taken this initiative to speak about it and make it available to the public.
Thank you so much. It was indeed wonderful. Great questions, and I'm sure the deliberations would find, would resonate with many more and help create the culture that we were talking about. Thank you.
Thank you, sir. I appreciate it.